Calhoun, National Director of Priests for Life. Welcome to this episode of our EndAbortion.tv series. We are very happy today to be joined by Dr. Byron Calhoun. Now, he is one of our medical advisors for Priests for Life. We have been working with him for many different years in this great movement. And Dr. Calhoun, welcome to our program. It's nice to talk to you again.
Thank you for having me. I appreciate it.
I'd like to, first of all, for our viewers that are not already acquainted with you, let us know a little bit about your own qualifications and experience, because that provides an important context for the discussion we're going to have. You, of course, are in the area of maternal fetal medicine. Explain to our viewers what that is and your experience in that field.
Sure. The maternal fetal medicine is a subspecialty of obstetrics and gynecology. So you do a general residency in obstetrics and gynecology, and then I did a fellowship in maternal fetal medicine. I did 2 more years, and I've been doing maternal fetal medicine about 30 years now. I find it hard to believe it is true, and I've spent a long time doing this.
That's also the length of time I've been a priest, and those decades go by real quick, don't they?
Sure do.
So maternal fetal medicine, then, in other words, this is that area where we're dealing with complications of pregnancy, right, that might endanger either the child, the mother, or both, right? Correct.
In obstetrics and gynecology, we always have 2 patients. And in maternal fetal medicine, we focus on both the mother and the baby. Mm-hmm. And of course, I take care of the sickest of the sick, the hypertensive, diabetics, mothers with complicated abnormalities, cardiac defects in the babies, maternal heart defects, all of the things that you would imagine complicating medically people or women, I take care of while they're pregnant.
So let's talk about this, because obviously, people are hearing a lot in these days about late-term abortion, about even babies being born alive as a result of a failed abortion. And as you know, the other side, the abortion advocates, always try to say, well, when abortions are done very late in pregnancy, they try to lead people to believe that it is only because of medical complications. So I want to get to that question in a moment, but I think if we can set the stage and give our viewers a little bit of an idea of, when it comes to pregnancy and childbirth, how frequent are the kinds of medical complications of pregnancy that might really be endangering a mother's life or health? What's the rough ballpark of the percentage of pregnancies that end up facing those kinds of challenges?
Well, fortunately, it's actually not that high a percentage. Probably, I would say, less than maybe 1 or 2% really have the medical complications that are severe enough that we would talk about endangering their lives and requiring us to perhaps deliver their pregnancy or end their pregnancy early. The good news is, as you've sort of alluded, is that we're now able to resuscitate babies down to 23 weeks. So we routinely now take care of mothers and deliver them at 23 to 24 weeks and actually have rather good outcomes. So when we talk about these abortion procedures, they're not necessary. For the most part, they're really not. You just deliver the baby alive, resuscitate, and end the pregnancy and save the mother and the baby's life and do the best for life. So
yes. Well, that is a very important distinction, as you know so well, and I want to kind of put a spotlight on that for a moment and an exclamation point, that there is a big difference between ending a pregnancy versus ending the life of a baby. When we hear about doctors saying, for example, oh, well, you have to have this abortion to save your life. Now, when we hear the word abortion, I mean, we understand that to be the direct intentional killing of the baby. So as a maternal fetal medicine doctor, let's ask you the question very simply: is the killing of the baby ever a medical benefit for the mother? Or is it not a question of simply ending the pregnancy early if necessary, and then, as you said, treating both of your patients, the baby and the mother?
And that really is the distinction. Direct killing of the baby is not necessary. I have delivered a handful of patients really before the 22 to 23 week time frame that have had to be delivered because mother was so sick we had to deliver them. And those babies did not have to be killed. They were born prematurely and died from prematurity. But the death of the baby was not necessary to save the life of the mother. Mm-hmm. That's the important distinction that really needs to be made.
Yes, because the abortion, I mean, whether it's going to be a dismemberment or inserting digoxin into the heart to stop the heartbeat or some other kind of way of killing that child, if I'm understanding what you're saying, it's the process of pregnancy, itself may be posing certain medical threats to the mother. And I'd like to get into a couple of details of what those challenges might be. But it is not in any way the death of the child that benefits her. It's the completion of the process of pregnancy, right?
Correct. It's the pregnancy being delivered, or the end of the pregnancy, that allows the mother to recover. Yeah. And that, again, is much rarer than people would paint it. Right. I mean, we do have people that, like we talked about, you said there are people that get high blood pressure, preeclampsia, that we have to deliver for those reasons. Sometimes we have mothers who have complicated cardiac or heart defects that we have to deliver them for. But they aren't that common that they need to be extremely prematurely delivered by 23 or 24 weeks. And we certainly don't have to take the life of the baby. We merely have to deliver that baby and then resuscitate the baby and try to save its life as well as mother's.
So you made reference already to, it's amazing how much earlier in pregnancy than most people realize a baby can be delivered and have a good chance of survival. Tell us again about some of those numbers. We're talking about sometimes 22, 23, certainly 24 weeks, right?
Correct, and it depends on obviously the nursery, but if you have a good nursery like we have here, 23 to 24 week babies will probably about 25 to 40% survival rates or more. Once you get up to 25 or 6, it's about 80%, and at 28 weeks, believe it or not, it's 93 to 95%.
Wow!
And 90 to 95% are normal, intact. They have no deficits for the most part. Now, so even the premature ones, maybe half of those have some deficits as well. Yeah. But many of those aren't severe. So you have to put in the context of what you're talking about.
And the challenge for the baby being delivered early is mostly revolves around the respiratory system, right? The development of the lungs. Is that right?
Correct, and that directly then affects the pressures and the other things that affect the baby's brain, which are actually the huge swings in both blood pressure and pulmonary lung pressures that cause the brain bleeds in these real premature babies, which is what causes the problems. So as we got better ventilators and we have better medicines, we're doing much better with our outcomes.
Talk to us about prolonging the pregnancy. In other words, if the doctor sees that there's a problem on the horizon or a problem already underway where pregnancy is threatening the mother's health or life, you can nevertheless very often prolong that as much as is safe so that the baby develops more. And isn't there even some kind of intervention where you can help the baby's lungs develop a little bit more quickly so that when you do an early delivery, there's a greater chance of survival?
Yes, we've used steroids for a long time. It's glucocorticoids or glucosteroids, particularly intramuscular. We use a lot of what's called beta-methasone, and we treat the mother and give her 2 injections of that about 24 hours apart, and that hastens the baby's lung maturity and lets them have less time on the ventilator and less pressure, and actually works quite well. Then also now we've developed, after the baby's delivered, we've developed artificial, what's called surfactant, which essentially allows the lungs to inflate better. Like you would be able to inflate a balloon better, the surfactant allows the baby's lungs to inflate, and that's been a tremendous advance. We also have made tremendous advances in the ventilators. We have oscillating ventilators with lower pressures. We've just got a much better technology to help these premature babies do much, much better.
You know, when I say to people, it's never necessary to kill the baby to save the mother, sometimes people will say to me, yeah, but you're not a doctor. And I said, yeah, I know, but I know how to listen to what doctors are saying. And that's one of the reasons that it's so great that all of our listeners and viewers are able to hear it directly from you right now that, hey, we don't know the detail of medical technology like you do, but it's certainly easy to understand the words that you're telling us, that you do not have to kill a baby in order to save a mother. It really is a false dichotomy that's being set up here. And I think it's just, it's just helpful to the cause of the other side.
Well, it really is. It's like I tell you, it's like the movie Sophie's Choice. You're trying to make it like there's no other choice but to take the life of the baby. That's not true. In general, you can save the baby and the mother just by delivering the baby early. And if the baby's too premature to live, you still don't have to directly kill it to save the life of the mother. You may have to deliver early, but you don't have to take the life of the mother. You never have to do that.
Well, we're going to take a little... Yeah, well, we appreciate that clarity. We're going to take a little break here, and then Dr. Calhoun, when we come back, I want to talk a little bit more about some of these methods of the late-term abortions, why a baby might even end up surviving an abortion procedure. I think a lot of people don't understand that. And then we'll talk a little bit more about the maternal fetal medicine, and also, of course, I want to mention the perinatal hospice before we finish. But let's take a little break, friends, and stay with us now, talking with maternal fetal medicine Dr. Byron Calhoun, also a medical advisor for Priests for Life, and we'll be right back with more discussion with him. Now stay tuned for this message from evangelist Alveda King.
Hello, I'm evangelist Alveda King with Priests for Life. The great issues of social justice, civil rights, and pro-life in our nation have made progress when citizens take their convictions into the voting booth. It's not enough simply to believe or speak about what is right. We have to elect lawmakers who will pass the right laws. As my uncle, Reverend Dr. Martin Luther King Jr. said, "The law can't make my brother love me, but it can stop him from lynching me." Making laws and changing hearts go hand in hand. When people's hearts and minds are changed, they will elect people who will change laws and court decisions. So, dear friends, if you're not yet registered to vote, please register today. And when you do go into that polling place, please vote pro-life.
Well, friends, welcome back. Father Frank Pavone here, National Director of Priests for Life. One of our medical advisors is Dr. Byron Calhoun. He's a specialist in maternal fetal medicine, dealing with complications of pregnancy, helping both baby and mom to be healthy, to be strong, and to get through any of those medical challenges. So, Dr. Calhoun, we're hearing a lot in these days about late-term abortion, thanks to a number of states, as you know, that have passed laws or are introducing laws that would make it even easier to get an abortion in the final months of the pregnancy, something that, of course, has been going on, but that a lot of people have not realized until now is actually going on. When it comes to these abortions in the latest stages of pregnancy, especially once a baby can be delivered and, as we already discussed, can survive, or at least high rate of survival, how are these abortions performed in the latest stages of pregnancy?
Well, it depends on the individual who's performing the abortion. It depends on their skill level, and it depends on what sort of abortion they want to do. The ones that have been most commonly done because they want to end up with a dead baby, which is really the result of an abortion, right? They really want a dead baby, are the destructive procedures, which are the dilatation and extractions or dismemberment abortions that have been so highly discussed because they're extremely gruesome. They're very obviously destructive to the fetus, and they can be very dangerous to the mothers because it's a major surgical procedure, and you get sharp pieces of bone, and you're putting instruments inside the uterus. So they tend to be a little more dangerous. The other type of abortion that has a lot been talked about are the prostaglandin abortions that are essentially mothers are put into labor using prostaglandins to help ripen and or cause contractions, and then using Pitocin to complete the labor and deliver the baby. The issue with prostaglandin type inductions is that the babies oftentimes are born alive because prostaglandins and Pitocin are not lethal to the fetus. In fact, they're used all the time appropriately for normal labor and delivery. So that's the issue that the abortionists are really concerned about, is a live baby. Because now what are you going to do with the live baby?
Right.
The other part of that is that most of the abortionists will often do lethal injections, as you pointed out, either with potassium chloride or digoxin into the fetal heart, do something to cause the death of the baby prior to delivery, so then they can do the labor type delivery and have a prostaglandin or Pitocin delivery.
You know, you may recall one of the times you visited with us, I had you examine some actual bodies of aborted babies that had been entrusted to us for burial. And I remember you describing there were bruises on these babies' bodies, and it looked as though they were a result of these prostaglandin abortions. Am I correct in recalling that it is these strong contractions that are induced that actually bruise and kill those babies?
Yes, and that's generally what they are hoping will happen when they do the prostaglandins. They give high dose.
Yeah.
They're really hard contractions.
Yeah.
Yes.
Yeah. And so people shouldn't be surprised. I mean, sometimes they think that we in the pro-life movement are imagining or making up these scenarios where, in fact, in an abortion clinic or in a hospital that does abortions, you may have an abortionist setting out to kill that baby and ending up with a baby outside the mother's body who's still alive. So in other words, that would be a result, most likely, of these situations where they're actually inducing early labor and in a very strong way, where these contractions are they're hoping that they would kill the baby, but they don't end up doing that.
Right, and the babies were born alive, and now you have a 32 or 34 week, very survivable baby. Essentially has the same survival rate as a term baby.
Yes.
And now, what do you do now?
Yeah, yeah. And that, of course, is why it's so necessary, as our viewers have been hearing from me, that these laws be passed that make very explicit that such a child should be brought to a hospital, cared for, and protected as a person. Let's talk a little bit about, in terms of maternal fetal medicine. Now, I also, one of the occasions that I've been together with you has been actually at some of these medical conferences, and I know that along with yourself, there are various other very strongly pro-life, highly experienced maternal fetal medicine specialists all around the country, and that you have all come together at various times for meetings and to discuss pro-life issues. And I always say to our viewers, listen, anyone anywhere who is told by their doctor, oh, you know, you really should have an abortion, or you really need to have an abortion for your health, for your life, I said, listen, get another doctor. And I always tell them, we can refer you to maternal fetal medicine, pro-life specialists all around this country. And like you're saying now, you know, there's a way that can be worked out for the good of both the mother and the child. Tell us about some of your colleagues in this field and about some of the great interaction that I've seen, you know, with the pro-life maternal fetal medicine specialists.
We've had meetings off and on for, well, it's probably been over 20 years now, where we actually would meet at the one of the national meetings, the Society of Maternal Fetal Medicine meeting, and also at the American College meeting. And we would have presentations by various maternal fetal medicines or obstetricians, gynecologists, regarding various topics. And so one of the big topics we've talked a lot about is just this issue about how to talk to people about serious illness and about how to take good care of moms and provide the best care for both mother and baby. We've talked a lot about perinatal hospice. We've talked a lot about early deliveries for various reasons. We've talked about how we could influence people better to know about the fact that you don't need to take the life of a baby to save the mother's life, that we can work on that particular issue. And there's just a good interaction with everybody, and they've had lots of very good discussions, actually.
I've been very impressed by it, and of course, one of the workshops I attended there that was of very great interest was that on fetal surgery. And, we're more and more able in our day now to do surgery on the unborn child, aren't we? And I know there's several places around the country that really specialize in this.
Correct. There are really fetal treatment centers, quite a number of them now. There locally, we have one in Cincinnati, Pittsburgh. There's also one in Nashville. There's fetal treatment centers in Columbus, Ohio, San Francisco. There's New York, obviously has their fetal centers at, I believe they're at SUNY New York, and then Baltimore has it, Johns Hopkins. Down in Tampa, there's ones. Detroit has a really good treatment center. Chicago. So they're in Los Angeles. There's treatment centers everywhere doing treatment and surgery on babies who before would not have survived or would not have done as well before the advent of fetal in utero surgeries.
It's awesome. Final point before we have to conclude, you have been a pioneer in the area of perinatal hospice. Now, people, of course, are familiar with the hospice program when they have a loved one who is dying, and the family is involved in the whole process of loving that person, caring for that person in a safe home environment, and so on. But explain to us about perinatal hospice.
Well, basically, it's taking the hospice concepts to before you're born. We believe that children, before they're born, are as members of the family just like everybody else. And so it's a concept where we allow parents, as I say, to be parents. They prepare for the birth of their child and perhaps the too soon departure from the world of this child, and are able to spend every moment that they would like loving that child with their family and with those who are with them. And it's applied really to children who really have lethal or non-survivable anomalies for very long periods of time. And so really it allows people to just gather around and hold these people close. And it's a really beautiful thing to see. And people really have rallied to it because it's just allows parents to be parents, like we say.
Now, you wrote some of the initial articles on this perinatal hospice concept that I ever saw, and it's been growing, hasn't it? When was it that this first sort of got off the ground, and to what extent has it grown?
Well, we started writing about this in the early 1990s, and then I actually had some interaction with Amy Kubelbeck, who actually took this on as she was a writer for the AP and was a really talented writer, great organizer. And she had a child who actually died from a hypoplastic left heart. He was very, very seriously ill and could not be repaired at the time when he was born. And so she took on organizing and talking about and providing a website and all sorts of basically chat rooms and other things for this, and putting together all sorts of information. There's now, I think, over 300 perinatal hospice in the world. It's just phenomenal, the growth in the last about 20, 25 years. And there's a perinatal palliative care board now. So there's some really wonderful things that have happened because of this this idea being spread around. But with God's grace, I say, it's just a wonderful thing to see it.
It's a wonderful thing, and I think we can sum up this whole conversation by reminding our listeners and viewers there are options. No matter what the situation is that you're facing, medically with yourself, medically with your baby, certainly social problems and pressures, all of us are here to help you. All of us within the pro-life movement, people in the medical profession like Dr. Calhoun and his associates, all of us at Priests for Life and many other groups, there are always options. Never, never does anyone have to feel that they must have an abortion, no matter how dark the situation might seem. So Dr. Calhoun, we want to thank you for these very informative answers to these very, very important questions. And we look forward to continuing our collaboration with you. I look forward to seeing you soon. And just blessings to you, to your family, and on your work, which is so important, especially in our day.
Well, thanks for having me. I appreciate it. Love what you guys do. It's wonderful. It's awesome stuff.
Thanks so much. We'll talk soon.
All right. Bye-bye.
God bless you all, friends. Father Frank Pavone here of Priests for Life.
But you know what? When you and I take up this call and we talk about abortion, if we speak about it in church, we're told we're too political. If we speak about it in the political arena, we're told we're too religious. If we speak about it in the world of the media, it's too disturbing. In the world of business, it's too distracting. In the world of education, it's too controversial. In the streets, it's too disruptive. So abortion, if abortion is wrong, where do we go to say so? We go into the churches, we go into politics, into the media, into business, into education, and into